Okay, thank you for joining us today. Today we have Dr. Timothy Pawlik joining us from Ohio. He will be talking about how to manage complications. Thank you, Dr. Pawlik, and the floor is yours.
Thanks, Hisham. So again, thanks everyone for welcoming me virtually to this meeting. I've talked in this forum a couple different times, and as you maybe overheard as we were chatting before this got started, I think I'll be coming to Egypt the first week of November, Cairo. So hopefully there'll be a chance to meet some of you in person. I would really enjoy that. So in previous conversations, we've talked about a number of different technically difficult surgical operations, whether it be for intrahepatic cholangiocarcinoma, hepatocellular carcinoma, gallbladder cancer. But suffice it to say that, as kind of complex GI surgeons, HPB surgeons, we will encounter complications. We will encounter morbidity and mortality. And I think there's a growing recognition that we need to talk about this, and we need to think more purposefully about how we can cope with this. And so this is a talk that I actually gave at the IHPBA in Cape Town earlier this year. And I think, as I mentioned, to error is human. So I always say that if people say they don't have complications, I typically think one of two things is happening. Either one, they are lying, or two, they are not operating. Because no matter how good you are, the PGA will leak, and you will get a biloma. And if you're doing big enough liver cases, someone will have liver insufficiency. It is inevitable that you will have complications. And so, I think that's just part of our life, and perhaps part of the reason why we choose to go into this field, because we're very resilient people, and we're able to bounce back quickly when we encounter difficult cases or difficult complications. And so, this is this seminal book from Charles Bosk, and saying, forgive and remember. So there's sense in surgery that at M&M we forgive, but we never forget, right? And we don't want to forget, but we also still want to be able to recover, right? So how, when you experience a very significant complication, can you not forget it because we want to learn from it, but yet not be destroyed by it, right? Because as surgeons, we need to maintain our confidence. And if we're constantly thinking of our last error or our last complications, it may cause us to second guess, and may inhibit high performing in future surgeries. So this is this article that was in, I believe, Annals of Surgery, looking at the emotional responses after postoperative complications. And it was an interesting article because it was a qualitative study that basically asked surgeons about their emotional responses after experiencing a complication. And this can be difficult for us because, as I noted, the prevailing culture in surgery is that we're kind of trained to be very confident and fallible, right? Never, sometimes wrong, never in doubt. We always know what we want to do. We encounter patients who are vulnerable, but our patients do not want us to be vulnerable, right? They want us to be decisive, and they see us infallible. And they want very clear answers from us, right? Can you get it out? Can you cure me? Can you help me? And anytime there's some type of unexpected complication, this can be very kind of dystonic to our ego, of our sense of self as being infallible, the sense of patient's family and patients thinking of us as being infallible. And then having a complication kind of introduces this idea of fallibility, and kind of stigmatizes us that maybe we can't deliver on what the patient had hoped for or what we had promised. So when we encounter this type of adversity, there's a number of different reactions that can occur. Whenever we encounter some type of difficulties, there's always this kind of initial decline, if you will, right? Where we're kind of put on our heels, and we feel bad about it, and it makes us question ourselves. But then after a little bit of time, there are multiple different pathways that one can take. People can recover. People can actually thrive. They can feel like, well, now I've experienced that. Now I'm going to be even better than before. And then unfortunately, some people can survive, but they're always impaired, right? They're always never quite. And I know some surgeons who had some bad complications and they were never quite able to fully recover. And they even changed their practice or who they would operate on, and kind of, averted many challenging operations, and then succumbing. And I've even known at least one or two surgeons that have completely left the practice of surgery after having very significant complications. So, it bears discussing the psychosocial impact of surgical complications, and this is a scoping review. And it's this idea of, the second victim. So, the first victim is obviously the patient, and they suffer that whatever morbidity or mortality may be associated with that complication. But then the second victim is the surgeon or the nurse or the PA or someone on the care team. And the factors that place someone at particular risk may be experience. So obviously, if you've been in practice for 25 years and you have a significant complication, it's going to be 1 out of 1,000 or 1 out of 2,000. You're going to have more resilience. If you're a new faculty member and this is your first or second case, that can be quite devastating, and you may not be able to get over it. Also, the culture in your department or your group, are people supportive, or are they kind of ostracizing you? And then the third victim is really the hospital, right? Because as we have bad outcomes and it may affect us, it could also affect the hospital's reputation, and also even like the internal politics in the hospital of how nurses view you, or how other faculty members view you. And so this biopsychosocial impact of the second victim, the caregiver, can really manifest itself into emotional changes, behavioral changes, or psychological changes. And therefore, it's important to be familiar with different coping techniques so that when you're faced with this type of biopsychosocial stressor due to a complication, that hopefully you can cope with it by using some specific behavioral techniques, but there's also relying on different support systems that may be in place. So what has been described as the 4 kind of steps, if you will, of the emotional impact of adverse events are categorized here: the so-called kick, the fall, the recovery, and the long-term impact. The so-called kick is that visceral blow to the core, right? When you're like, just feel like someone kicked you in the gut, and that someone had a PJ leak and now they're septic and you feel horrible. And here's a quote from one surgeon saying, "I honestly felt like I crashed into 4 parked cars leaving the garage." And this is, as I noted, you have these feelings of failure, self-doubt, and unworthiness, that it's like I failed. I'm not entitled to be a surgeon or wear this white coat. And I always say to residents, unlike in medicine, if someone has hypertension and they die of like a stroke or something, you don't feel like that's your fault. Yeah, you've been prescribing them hypertension medications, but it's not really your fault. But as surgeons, we feel like it's our fault. And because it kind of is our fault, right? We're the proximate cause. Like, you were the one holding the needle driver. You were the one putting the stitches into the pancreas. So when that leaks, there is a very clear ownership that complication rests on me. And then after the kick, there's usually the fall, right? Maybe the next day or the next week, this feeling of like spiraling out of control, or maybe this self-doubt, you can't sleep, and these questioning of yourself: did I miss something? Should I put that extra stitch in, right? Or, I thought it was dry. Should I have checked again? And this feeling that you're just questioning yourself in the next case. So then the recovery, and this can take on a lot of different pathways, and that's getting over things. And it does take some time. Time doesn't heal everything, but time is a solve for many things, because the emotions become less raw. And then you have the next case. And frankly, sometimes I find after I have a complication, some of the best thing to do is just the next case, right, is if you get a case tomorrow, you're right back in it. You get right back on the horse. And that can help. I think sometimes people cancel cases. I haven't found that to be helpful. I feel like you need to kind of reorient yourself, reground yourself, get the help that you need, but then forge ahead. And then with regards to long-term impact, as I noted, these cumulative effects can really affect you as a person and as a self, and it may impact your professional or personal identities, and in some cases have resulted in people changing their career or even changing their practice significantly. And interestingly, if you look at some empiric data, you ask surgeons, when did they experience their first complication? And most of the time it's in residency. I think that's the case because in medical school, you really don't feel responsible, right? You're like just holding a retractor, and if something leaks, someone bleeds, you're like, it's not my fault, right? But resident is the first time where you're really starting to do a case, at least here in the United States. So I think that's when you start feeling like some ownership to good outcomes and bad outcomes. And it's interesting if you ask, the complication impaired my functioning, while there were a number of people who said disagree, there were, 15 out of 60. So, that's about, 20% of surgeons said that they strongly agree that it impaired their function. So if you look at surgical trainees, since most of the time people experience their first complication as a resident, and this is where people are often very, very susceptible because they don't have much experience under their belt. And also they're just starting off. So, having a serious complication very early on can be quite crushing to people. There's been some interest around how we as faculty members can help trainees kind of process and handle their errors. And I think it's really important that senior people have mentor-mentee relationships with junior people. And the biggest thing that has been shown to help people work their way through complications is peer support. Right, because if I go home and talk to my wife about it or whoever, they don't understand. They want to understand, but they can't understand. The people really understand is other people who have been in the arena, right? So if I talk to Hisham and I talk about like a complication, you can relate. And you're like, oh yeah, I remember that patient I had, and that thing leaked, and I felt horrible, and this is how I got through it. So we really need this peer support. And for junior residents and junior faculty, really rely on senior people to provide that peer support. Because if you look at the impact of surgical complications on the operating surgeon, it can be quite significant. I mean, these are self-reported outcomes. Surgeons feel guilt, crisis of confidence, worrying for patients, anxiety, sadness. And you can see, again, this is what leads to folks having depression and burnout in surgery. And if you look at the effect on their surgical practice, not an insignificant amount of surgeons, as I noted, become more cautious or more risk adverse with regards to their selection of patients. So again, these are the emotions: shame, guilt, fear, panic, shock, humiliation, and embarrassment. And all of these can be drilled down upon, this idea of, guilt that you could have prevented the adverse outcome, the stress that it's going to harm my personal and professional identity, that other people are going to think less of me, I'm going to get sued. Anxiety that if you do the same case, you're going to have another bad outcome, frustration and anger at the patient, right? If they had only been, skinnier, or if they had only not smoked, or they wouldn't have had that bad complication, or anger at yourself for not like double checking something or triple checking someone. And then finally, again, these feelings of insecurity and self-doubt. So, the three P's are, personalization, pervasiveness and permanence that people often feel, that the personalization that it was all my fault, pervasiveness that I'm just a bad surgeon, not separating that I had a bad outcome or I had a bad day or a bad case, but then it becomes pervasive, right? That this is going to affect all my practice, and then permanence, that this is going to last forever and that I'm not going to be able to get over it. And I think it's important as peer mentors to remind people that everything is never any one person's fault, right? It's always a constellation of symptoms, and that everything affects everything else, and that you can change and learn from this complication and be better in the future. And that, as I mentioned, time heals many things, and that this isn't permanent. And with time, you will feel somewhat better. But part of that process of feeling better is to explore the emotional responses. And as I mentioned, here are some of the emotional responses in the middle: sadness, grief, failure, disappointment, and some of the internal processes and the external pressures that one may feel. And so I think this is a helpful conceptual model when trying to understand the emotional response of a surgeon when they suffer a significant complication. And what this really manifests into is this kind of more general notion of moral injury. And this is this sense that it's what occurs to us as surgeons when we feel like patients entrusted us to care for them, and there was a major adverse event, right? We feel a deep sense of like moral injury and failure that we have to bear witness to, both publicly and privately. But moral injury and burnout are not synonyms, right? Burnout can occur from many different reasons. Moral injury has more to do with this deep sense of kind of letting someone down or failing someone, but they are related. And you can see here that people who had a higher degree of medical errors are much more likely to have emotional exhaustion. And then they're also more likely to undergo this depersonalization, probably as a defense mechanism, right? Because it's just too much. I can't handle this. It's too emotional. So I start to like separate and depersonalize things. But it's important to know that moral injury over time can, again, lead to this second victim syndrome that I talked about. And this is the kind of seminal article by Albert Wu, who's actually one of my colleagues at Hopkins when I was there, who first coined the term second victim, that being the care provider who can suffer and then over time lead to people leaving medicine or spiraling down and having persistently worse outcomes, or depersonalizing their colleagues and or their patients. And the second victim can be kind of categorized into these different stages of, as I mentioned, like chaos and accident response. How could this have happened? Then, intrusive reflections. What could I have done? I should have done something different. Personal integrity. What are other people going to think of me? And then like enduring inquisition. Am I going to get sued? Am I going to get fired? And then finally, hopefully moving on to emotional first aid, which I noted is most important in the form of peer support. And this is an article that was written by one of my friends, Sunil Gervisi, talking about moral injury and how we can address and stop the progression of moral injury. And this is a book that I like, David and Goliath. And it's this sense of, how we can learn from some of our mistakes and challenges, to kind of reframe this as, yes, it was a failure, but how can I reframe this as something that's going to make me stronger as a person? And this is where we want people to be, right? We don't want them to be on either side of this curve where, they are so overwhelmed by their complication that they have anxiety, PTSD, and even suicide. And recently I had one of my surgical friends actually attempted suicide, so this is real. And or that they're so post-traumatic that they can't grow. how can we develop resilience so we can learn from our mistakes and improve? And, this is this idea, Oscar Wilde, the famous writer, wrote, experience is a name everyone gives to their mistakes, right? So most of my experience comes from my mistakes. And even when I'm in the operating room, I tell the residents, I'm like, let me tell you, right? This is where we're doing it, or don't do it that way, because I learned I did it that way and it didn't work out, right? I had this complication. We got into bleeding if you do that. Or if you do this, I've had someone it's not turned out that well. If you didn't get the volumetrics beforehand and you're just going to wing it, you're going to end up with liver insufficiency. I tried that once. So all of us build up cumulative experience over time based on our mistakes. And again, this is this idea of bouncing back from our mistakes in order to avoid, just continuing to spiral down and self-destruction. So what are some of the coping mechanisms? Cognitive reframing. So this is this idea of thinking of desirable difficulties, that this is a difficult moment, but I'm going to lean into it. I'm going to embrace it and I'm going to learn from it. I think for some people, meditating or mindfulness exercising, it can be journaling, writing things down can be helpful. I think, trying to avoid it or bury it or whitewash it with toxic positivity usually does not help. I think, the meaning is really important, right? If I can learn from this mistake and I'm not going to do it again, and other patients are going to benefit because I learned from this complication or error, then I think that can be uplifting. As I mentioned, I think one of the most important things is social coping, which is professional support, usually peer support from a trusted friend. And as I've noted, the most helpful support comes from those who have suffered similar losses. So if you can open up about these traumatic experiences and complications, that is the most powerful way to avoid, I think, long-term psychological and physical health issues. Hopefully you're in an environment where you have a peer support group that has these 4 ingredients of curiosity, understanding, validating you, and being empathetic towards you. And during the AHPBA in 2025, we actually invited Joe Shapiro from Harvard University, who has peer support as one of her main career goals. She's actually a national, international expert in peer support to mitigate the emotional toll of medical errors. And I would recommend that you use this QR code if you're interested and take a picture of it. It will take you to Dr. Shapiro's website, where she has a very in-depth program around wellness, building a trust of culture, peer support, and how one can help our colleagues who are suffering through the emotional tolls of either complications or other challenges that we face as surgeons. And if you look at Dr. Shapiro's work, these are some of the key components of peer support conversations, that include, listening and reflecting, reframing, sense making. So again, many of the themes that we have already touched on earlier in this talk. And I think also what's helpful in this article is kind of this stylized language that she provides, sample language to help you introduce it, because many of us have not been taught this. But, just being there, like, can you tell me what happened? How you doing? These events can be traumatic. What are you feeling right now? And then being vulnerable and opening up and saying, you know what? I had a bad complication once. This is what happened. Let me tell you about it, right? So you get this sense that you're not in it alone and that this person can really not only be sympathetic, but empathetic. And one of the key points, I think, is really making sure that we reframe for our colleagues that you are not the error, right? You committed an error, I committed an error, but you are not the error. And to separate the person from the act and to help them understand that they're doing lots and lots of good but occasionally, we will make errors, and that you can help them prevent making a similar letter by learning from this experience. And out of that, it can be reframed in a very positive way to help actually improve their practice over time and help them build resilience, excuse me. So as part of this, the HPBA actually trained 16 peer support leaders with Dr. Shapiro. And this peer support is open to all AHPBA members. I'm not sure if it's open to IHPBA members, but it's actually a pretty neat program because sometimes we want to talk to peers about our complications, but we may not want to talk to peers at our institution, right? Because we want some type of anonymity, and we're a little bit worried about our reputation, but I might want to talk to someone else at a different institution. And what this program allows is these 16 people have been trained as peer support leaders, and using this QR code, you can be connected to one of those 16 people. So if you feel like you need support and you want it to be somewhat anonymous, you can reach out to one of these trained individuals and engage with them around peer support. And all communication are kept strictly confidential. So I think this is a wonderful program, and it's something that's super important and super needed. And then finally, I think, all this conversation kind of bears talking a little bit about Morbidity and Mortality Conference and reframing the culture of that conference, right? And it's this delicate balance of, holding people accountable, but also creating, a learning environment that is not meant to be punitive. We're not meant to shame someone, beat someone down. This idea that errors are inevitable, but errors are also avoidable. And I struggle with that sometimes, right? I don't want to be like, yeah, it's okay, that leak, don't worry about it, right? There's no accountability. We don't want to be there, but we also don't want to be like, you're horrible, you're a bad person. How did you let that leak? What were you thinking of? You're an idiot. And so how do we create like M&M conferences that can be supportive to folks, but yet hold them accountable and help people learn? So with that, I'll end. Glad to talk with you all today. I'll put one plug in. So we wrote a book. This book is on gastrointestinal surgery, and it doesn't talk about psychological coping with complications, but it's actually, I think, a good book that has experts talking about how to manage complications, right? Because frequently in textbooks, we talk a lot about like epidemiology, pathophysiology, imaging, treatment, but like, how do you treat those tough complications, right? And this is a book that goes through the entire kind of GI system, and whether it's like that bad esophageal leak or, a persistent bile leak or, a bad pelvic abscess, it takes you through how the experts manage these complications to try to achieve good outcomes in the face of difficult situations. So with that, I'll conclude. I'll stop sharing my screen. I'll be happy to answer any questions.
Thank you, Dr. Pawlik. It was a nice, different talk. Let's see if we have any questions from the audience. Please, if you have a question, raise your hand. Dr. Medhat.
Thank you, Dr. Pawlik. My question is, how many days it takes from you to forget, for example, if you have a post-operative mortality, forget it?
How long does it take you to process your emotions?
Yeah, I think it's two different questions. I don't think I ever forget it, right? I don't ever forget it.
You never forget.
I never forget it. I mean, like, I always think about those cases and things
Well,
like
I mean, 90% of.
When do you pass the sad phase? Like, when do you get over it?
Yeah, I mean, I think for me, it's different for every case, because I think there's some cases where, it's different than like if I did a Whipple and someone had like a big MI on day 3 and they passed away, right? You're like, I'm gonna think about that and I feel bad about that. I don't forget that. But if it's something where I feel like I didn't exercise the best judgment, like I was like, I don't know if I should operate on this person. I don't know. Okay, I'm going to operate on them. And then they have a bad outcome, then I'm like kicking myself for a long time saying, God, that was a bad decision. I knew I shouldn't operate on them. I thought I shouldn't do it. And then I was convinced to do it. You know what I mean? Or if in the operating room, we're making a decision, like it's a very difficult case and we're trying to figure out, like, should we forge ahead, bail out, we forge ahead, and then we get into bleeding. It's going to be different with each case to some degree. I don't know if that helps. I don't think there's like one answer. I'm never like over it
I
like all
think
the
it,
time in one day.
I think it
How
takes
about
like
that?
a week or two.
How about the response to mortality? Do you go to friends to ask them, or do you see in the literature if you didn't do the prophylactic measures against complication, or do you blame someone else for the catastrophe? What's your response?
Yeah, I mean, I try not to blame other people. I do try to talk to, everyone who is involved. Like the resident, the nurses, make sure everyone's doing okay. We all talk about it and think about it together. Like, what could we have done differently? Gosh, something was brewing. We should have got the CT last week. We waited too long, stuff like that, right? And then try to work together to talk about it. I think that's helpful for me rather than I don't keep to myself, right? I'm very much want to talk about it with other people on the team. The other thing here at Ohio State, if there's any interoperative death, I automatically get notified as the surgeon in chief, like immediately. It's automated in our EMR. So I get an email that says there's been an interoperative death in OR9, Dr. Smith. And then I immediately email Dr. Smith and say, I learned there's an interoperative death in your operating room today. I want to let you know that we're all here for you, that, these cases can be hard. If you need help, I'm here for you. And here's some other services for you. And then as a matter of process, every time there's an interoperative death, and there's not that many, right? But if there's one, they have to meet with the vice chair of quality in the department and debrief the case to make sure that, they're okay and that there were no system errors in the operating room, right? Like they needed something and because someone couldn't find it or something wasn't working. So we always make sure that people who have an interoperative death, are kind of reached out to immediately and have the support that they need.
Well, it's because it has a medical legal aspect. Intraoperative death has a medical legal aspect. I
You're
don't
right.
mean
It has a medical legal aspect, and I think it's been my experience that's like the most devastating complication for a surgeon. It's obviously horrible when someone dies post-op day.
Do you
15.
as a protocol for you in your Ohio State University or hospital, do you do some sort of peer review of any complications or mortality as a routine?
Yes. So
Do you have a system for that?
yeah, so everyone has a scorecard that we track that has
know
like
this
their
one.
ODE, so their observed to expected mortality, their readmission rate, their length of stay, their wound complication rate, all of that is tracked, and I see that whenever I want. And I have to sign off every 3 months. I have to go in and review all the faculty members' quality outcomes and then say, looks good, or there's a problem. So we track all of that. And then
You don't discuss with a peer review for any catastrophe.
yeah, so so that's what we do routinely.
That is statistics.
If there's a catastrophe or a sentinel case, then we do what's called a root cause analysis. Then there's like big investigation that looks for the root cause of why this happened. So in other words, you're right, like something happened a week ago. I can't talk about too much, but it was a catastrophe. It shouldn't have happened. Somebody died. And so there's going to be an investigation that now it's not like a punitive investigation, but yes, there's a huge debriefing, interviewing with a bunch of people. There's a committee that's set up to do that. And then they do a root cause analysis and produce a report that comes out with the causes and the remedies of how to avoid this in the future.
The report is secret, of course, because for fear of lawyers.
It's shared with,
Secret from
certain
the people.
people. Yeah, it's not like,
It's not
you know,
open for anyone.
yeah, right. But the outcomes of it are shared openly. So, the process improvement things are obviously shared openly, but not the details of the full report.
Fortunately, I worked for Memorial Sloan Kettering for 3 years as a resident fellow. There were just very minimal cases died during these 3 years of work. Very minimal. Because I observed that in MSKCC, there is a lot of prophylactic measures taken for patients to prevent complications. A lot of, on every stage, the surgeon, the nurse, the anesthetist, everything. There is a lot of prophylactic measures taken. So that the
Such as
mortality rate
what type of prophylactic
everything. Everything is, they do it in Memorial Sloan Kettering to prevent any complication or mortality. Everything there.
I think they do the same thing everywhere.
Yeah, I mean, everyone has complications, though. I mean, I have friends at Memorial. I mean, we all try to prevent complications, and we do everything. But even if you do everything, it's going to happen. Yeah, I mean, I was at Hopkins, and John Cameron, probably the most famous pancreatic surgeon. Even Dr. Cameron had complications, and he's the one who told me if you don't have complications, you're not operating. Or you're doing, I don't know, removing sebaceous cysts or something. But I mean, if you're operating on the pancreas, you're going to get a complication now and then. Yeah, it's just going to happen. Yeah. And we have M&M conference every week. So we also talk about mortality in that setting and morbidity at the department level.
Oh, easy.
Yeah. But I do think peer support is the most important thing, to provide.
Thank you.
You're welcome. Thanks for those great questions.
Any other questions? Please, if you have a question, raise your hand. Last chance to ask Dr. Pawlik. Dr. Pawlik, do you have a question for us?
I don't think so. I mean, I'd be curious. So do you all have M&M every week at your institution?
Not necessarily every week. Yeah, like we have a weekly, maybe every month. We have a weekly conference, and what we discuss in this conference varies every week. But I'd say every once a month we have a morbidity and mortality.
And then who presents? The
residents.
The residents
present, and supposedly the operating surgeon should attend, but this doesn't necessarily happen every time. And sometimes it goes well, and sometimes it's like they hang the resident.
Yeah.
Well, we are in a better shape than you, because people in Egypt, they believe everything is determined by God. And so the surgeon will rely on that we cannot prevent it. This is God who did
it's
it.
God's will.
Yeah,
and you don't have that attitude in the United States.
No.
They
blame everything on the doctor.
Yeah. We are very lucky for that.
Yeah.
We have another question.
Ajaz?
Yeah, Dr. Ajaz.
Hi, good evening. Thanks for the very important talk. It's often overlooked in the academia that we are all going through.
Dr. Ajaz, can you tell us where you're from?
I'm from India.
Okay.
So I wanted your feedback on two things. Number one, Is there a difference between how you cope up between a patient like who comes in for an elective procedure and has a complication and doesn't do well, as compared to a patient like who comes in sick as in a shock or something, and then he doesn't do well? Any number one. Number two is that any feedbacks, and we on and off get all those, very important person, very important patients. Any how is the decision making different, or how do you deal with those patients?
Yeah, so you're talking about like when a very important person comes in, how do I deal with them differently with the residents and things like that? Is that the second
Everything about
question?
yes, everything about it. Your team. Is there anything?
I treat them exactly the same. Exactly the same. So, so even, whoever it is, we treat them all the same. The resident still participates, everything like that. So, I have found that when you start to like deviate and you start treating people special, like, if I ever come in, just treat me like everyone else, right? Because there's a machine, right? Everyone, and when you start trying to deviate and do things differently and you're second guessing, I just feel like you get off pathway. So I just do it the same way, kind of every time. And then your first question was what? Remind me?
Wait, I have to unmute him again.
The issue of having a complication in an
Oh,
elective
yeah.
setting versus an
Yeah.
complication
I
having
mean,
it in an emergency setting.
Yeah. I mean, I mean,
Does that provide us any solace, or?
I mean, I think it depends on what the emergency is, obviously. I mean, I think, when someone comes in extremis and, you're trying to help them out and then they die, I mean, sometimes, I don't feel as responsible, right? If someone came in and, I don't know, they have some ruptured like splenic artery aneurysm and they're dying and I'm trying to help them and you can't pull them through it. That's a lot different than taking somebody, who was completely healthy and playing tennis yesterday and you bring them in and you do an elective procedure on them and then something bad happens to them. And I even think for me, like sometimes, when you're operating on people for like benign disease versus malignant disease, I think you have to, I think about that, right? I'm like, oh gosh, man, I did this case and it was for a benign indication and now they got a bad complication. That stinks. It's different than if they have a bad cancer or something and you feel like, God, well, they had no real options. So at least for me, all those things do weigh into my response to an adverse outcome.
Thank you.
Yeah, thank you. And thanks for using the textbook.
Yeah, I know. Been a fan.
Yeah, we're working on the second edition.
Yeah, shall be waiting.
Great.
Okay, any other questions? Okay, I think that was it. Thank you, Dr. Pawlik. I'm looking
Yeah, you
forward to
bet. A
seeing
little bit
you
different topic
next
this time, but I still
Yeah,
think important one.
and we'll meet next month.
Yeah, I'll drop you an email, my friend.
Okay.
Okay.
Thank you all
Good to
for
see
joining.
everyone. Yep.
See you
Bye-bye.
next week. Bye-bye.
Yep. Bye-bye.